dignitaries, esteemed faculty, and dear delegates. A very good evening to one and all. I, Dr. Rishikesh, feel privileged to welcome you all on the of the entire team at Emcure Pharmaceuticals. Yeah, I take this opportunity to extend a warm welcome to our respected course director, Dr. M.S. Hiramat sir. Sir is director at Cath Lab Ruby Hall, Pune. He was president CSI 2017, program chair CSI Conference 2016, convener National Interventional Council of India, CSI 2004 to 2006. He has proctored many interventional cardiologists and has given live courses across the globe. Great experience in peripheral angioplasty, including legs, iliac, and carotids. He has participated in some groundbreaking clinical trials. Thank you, sir, for your continued commitment and guidance to us for running this program regularly. Your expertise and fan following has made this program a resounding success. Our distinguished moderators, Dr. C.B. Keshavamurthy sir and Dr. Girish Navsundi sir, are poised to share their knowledge, insights, and practical wisdom to empower us in the fight against the global health challenge of cardiac diseases. It is an honor for me to introduce our distinguished moderators for today. Dr. C.B. Keshavamurthy sir. Sir is Chief Consultant Interventional Cardiologist and HOD at Manipal Hospital, Mysore. He is past president of CSI Mysore chapter. He has pioneering work in primary angioplasty at Mysore. He established interventional cardiology centers at Salem and Erode, Tamil Nadu, and performed several first ever procedures in that region between 2000 to 2004. He has several national and few international publications and presentations to his credit. He has a teaching experience as DNB teacher at Vikram Hospital, Mysore. He is principal investigator of Rocket, AF, Reduce It, Credence, and Horizon trial, and 33 other national clinical trials and registry participation as primary and co-investigator. Thank you, sir, for joining today. We have Dr. Girish Navsundi, sir, with us as moderator today. Sir is senior interventional cardiologist and director at Cath Lab Apollo Hospital, Bangalore. Sir has extensive experience in the field of cardiology, performed over 1700 angiograms through femoral, radial, and ulnar approach. Sir has presented numerous research papers and he is written for several journals. Thank you, sir, for joining today. It is an honor for me to introduce esteemed speakers for today. I would like to introduce and extend a warm welcome to them. We have Dr. Samir Kubba, sir. Sir is Associate Director at Clinical and Interventional Cardiology, Dharamshila Narayana Super Speciality Hospital, Delhi. Sir will be presenting a case on inferior wall STEMI. What is the culprit vessel case today? We have another speaker for today, Dr. Gaurav Verma, sir. Sir is consultant cardiologist and director at SMBT Heart Institute, Nashik. Sir will be presenting a case on complex PCI. So let me brief you all on the meeting agenda for today. We'll kickstart the program with the opening remarks and context setting from our course director, Dr. Hiramat sir. The meeting will proceed further with the first case presentation by Dr. Samir Kubba sir. It will be followed by a panel discussion by the faculty, and then we'll have a second case presentation on complex PCI by Dr. Gaurav Verma sir. Then again our faculty will have a discussion around the case. Then we'll have concluding remarks by our respected course director, Dr. Hiramat sir. So without further ado, let's embark on this educational voyage together as we endeavor to enhance our understanding of interventional cardiology. I request Dr. Hiramat sir to share his opening remarks. Over to you, sir. Sir, please unmute yourself.
Sorry, good evening, everybody.
Good evening.
Thank you, Dr. Rishikesh, for that introduction of everybody. We move on to the first presentation by Dr. Samir Kubba. And this is the dilemma we always face, like inferior wall, which is the culprit artery? It is an RCA or it's an LCX. And there are various criteria, start beginning with the ECG and so on. So let's hear from Dr. Kubba, his case and how he sort of made a decision. Over to you, Dr. Kubba. Can we call you Samir?
Yes, absolutely. So thank you, sir, and thank you, Emcure. Thank you, Dr. Girish, Dr. Keshamurthy. So what I'll be presenting is something which we did about a month back in the middle of the night, and it's more about learning from you people also whether we did the right thing or no, and how things at times need to be taken in the middle of the night when you do not have all facilities available. And sometimes the newer technologies like imaging and physiology, which we talk about a lot, but in the setting of ACS probably may not be feasible and also may not be available at all centers. So anyhow, this was something which we routinely see. A 60-year-old smoker lady presented with inferior STEMI, referred from a nearby nursing home. The pulse was 110, the BP was 110 systolic. ECG showed an ST elevation in the inferior leads with ST depression in anterior leads. So we thought that it would be a proximal RCA occlusion, and a dominant RCA is what we would see. And she was loaded with aspirin and ticagrelor. So this was the ECG. Typically, as you can see, the ST elevation in lead 3 more than lead 2, ST depression in 1 AVL, V2 to V3, even V1. So this is what the ECG was. So we took her for the angiogram, and she was a very thin, frail lady. So
Dr. Samir, before taking her for angiogram, what was your mind thinking, whether it's going to be circumflex or whether it's going to be RCA? Just go back to the previous slide, and based on that, can you discuss?
Yeah, so we thought it would be RCA, the ST elevation in lead 3 more than lead 2, and ST depression in the anterior lead. So the ECG criteria actually suggested that it would be an RCA. Or sometimes a dominant circumflex can also do that. But we thought it would be an RCA, and we actually tried a radial approach, but she was very thin and frail, so we actually could not place a radial. So we did the angiogram through the femoral approach. Otherwise, we usually do our primaries and all procedures through the radial approach.
Dr. Keshamurthy, you have any comments at this stage on the ECG?
No, nothing at all. I think the interpretation is fair enough. And like you said, many a time, there's definitely a confusion between the territories. Though the criteria are there, they are sensitive and specific to the extent of about 70%, and many times we are misled by a dominant circumflex mimicking a proximal right coronary artery occlusion.
All right, back to you, Samir.
Yeah, so we just took this left shot, and we had some disease in the circumflex and significant disease in the LAD. In 2 points in the LAD, one near the septal origin, and then after the large diagonal, there was a very focal stenosis in the LAD. But anyhow, we thought that this is a flowing vessel and RCA would be culprit. So we just thought that we'll just quickly hook the RCA. And so we found that the RCA was pretty okay. I mean, there was some lesion probably in the proximal part, but that didn't appear to be critical. But the patient was continuing to have severe chest pain. STs were up. And so we looked at multiple views. We had a critical LAD lesion for sure in the left angiogram, but we thought we'll be quick. It would be RCA and we would stent it and come out. So then we took multiple views of the left side again, just to be sure. So as you can see, the LAD was actually, if you look at the anatomy of the The LAD and diagonal are almost similar size, something like a dual LAD. And if you see on the left side of the iliocranial view, where typically the LAD goes, there's a lesion proximally at the side where the septal is originating, and then there's a lesion at a great angle, very tight focal stenosis from the side where the diagonal is originating. And this is the anatomy that was there. So we were in a fix. So we took multiple views just to be sure. Circumflex also on the iliocaudal appeared to be around, say, 60-70%. Now all arteries were flowing. Patient was continuing to have angina.
No, you have ST elevation.
Yes,
correct?
we had ST elevation. We had ST elevation.
Looking at both circumflex and RCA, I mean, none of the arteries can give ST elevation. I mean, the lesions are not so tight to give ST elevation.
Absolutely. So that was our concern. It was an ST elevation in the inferior leads with ST depression in the anterior leads. But the LAD was the one which was critical. So if you look at this is the still image of the LAD. So the LAD was very, very critical, especially at this point. And we actually looked at it multiple times. In this view, even the circumflex appears to be around 70-75, but this was the one which was bothering me more than anything. And patient was continuing to have angina. She was in severe chest pain. So what to do? Do we just medically manage her as all her arteries were flowing? Do we stent the LCX? Do we stent the LAD? Do we stent both? Do we do imaging? We didn't have any imaging at that point of time. Do we consider physiology? Now, what we decided is we decided to stent the LAD. And it was difficult actually to wire this LAD. It was coming at a very acute angle. So we had to place, actually, I'm not showing in the interest of time, we had to place a wire in the diagonal, occlude the diagonal ostium with a balloon, and then we could negotiate this wire into the LAD, although it appears to be relatively easy, but we had problems at that point of time. And then subsequently we stented the
What wire
LAD.
did you take to LAD?
This was a run-through wire.
I would probably take something like Fielder FC, because
Yeah, so we have a default run-through as the choice. Then we took a whisper. We did not take Fielder. We took a whisper. That also had a problem, but then we occluded the side branch with a balloon, and then it was easy.
I wish you had brought some images of that side branch balloon occlusion. Anyway, go ahead.
Yeah,
Sorry.
so I mean, that is something which we have done in a couple of cases. So it was not for the interventional aspect much, but because of this ECG changes. And so we did that, and that was the final result. So nothing much technically from the intervention point of view. And then she stabilized. And after 24 hours, this was her ECG, significant ST segment settling. And as you can see in the inferior as well as in the lateral leads, you can see the anterolateral leads, the T wave inverting. And now it's almost 1.5 to 2 months of follow-up, and she is doing pretty well. The LV function is fairly preserved.
No, that means you did only LAD and nothing else?
Nothing else, nothing else. So RCA, obviously, we did not do. We found, as per the angiogram, RCA to be absolutely non-critical. There was some decision of taking care of the LCX. It appeared to be about 70% or so in one view, but the LAD was around 95%, and at that one point was actually very, very critical. And she became all right, and she has no angina now. Her ECG is settled. So now the question is, was it correct to stent the LAD at that point of time? We have seen that in the presence of anterior MI, you can have ST elevation in the inferior leads when it is a mid-LAD lesion. But isolated ST elevation in inferior leads is very, very unlikely to be associated with LAD culprit. Sometimes you have a distal LAD lesion, which especially wraps around the apex. So it's a wrap around LAD. It at times can cause an isolated ST elevation in the inferior leads. There's a case report which I came across recently was of an acute stent thrombosis of the proximal LAD, which produced only isolated ST elevation in the inferior leads without any changes in the anterior leads. Now, we could have a possibility of probably a RCA lesion which was recanalized. But again, the problem was the patient was still having an ST elevation and was having severe chest pain. So we had to do something at that point of time. And the anatomy, if you look at the LAD and the diagonal, that LAD probably, the diagonal was big, supplying the lateral wall. That LAD probably was going and supplying probably the inferior wall as well.
But your
it's
final
unlikely
pictures,
that the circumflex all actually. Yes, sir.
No, your final pictures Does it show a wraparound LED? I mean, you can make out after you're done angioplasty to LED. Let's see can we see the picture here? The one on the right might be able to show properly. This is not like a wraparound LED.
It doesn't look like a wraparound LED. It looks more like a type 2, just reaching the apex.
Yeah.
And like you rightly pointed out, completely wraparound LED with a non-dominant or codominant kind of right coronary artery can produce these changes. The other thing I just wanted to ask, sorry to interrupt, was there any regional wall motion abnormality on echo? Because that would give you a clue if there is an inferior wall hypokinesia or loss of thickness.
Yeah. So it was reported at the basal inferior wall, and the echo was reported as an LV of around 50%. This is the echo report. Hypokinesia of the basal, IVS, and the inferior walls. That was the echo report.
I think once you are in sort of question mark, which vessel is the culprit? Can't you do an echo in the cath lab yourself and make a decision which is the area which is not contracted? I mean, it would definitely help.
So let me just complete. So then when we came across this case report, isolated inferior ST elevation caused by occlusion of the left anterior descending artery. So in this case, what they saw was that the patient had an acute stent thrombosis. And what they postulated is that this probably is because of the electrical extracellular potential in the anterior walls versus the inferior walls, and something, if happens very acutely, can actually lead to an anterior myocardial tissue perfusion, which is severely affected initially, and then a negative electrical potential of the tissue under the injured front wall to become more pronounced. And then the vector actually shifts more towards the inferior wall. So this was something which was new to me. And at that point of time, I did not know this. I knew that at times we have treated distal LED lesions with ST elevation isolated in the inferior leads. But this kind of an ST elevation with this kind of an anatomy with moderate sort of a stenosis in the RCA and the LCX and a tight stenosis in the LAD with patient having angina, we just at that point of time did that. And then when we searched literature, we found that isolated ST elevation in the anterior MI presentation can happen with a very distal occlusion when the anterior muscle is actually much very well supplied by the proximal LAD and diagonal, and then the wraparound can actually cause an inferior wall ischemia. And sometimes there's a collateral flow from the LAD to the inferior wall, and this acute LAD stent thrombosis because of the electrical issues can at times cause this kind of an ST elevation.
No, but here I would feel the LAD occlusion would show an elevation in anterior lead. It could be an additional inferior leads. But here in your case, there were no. Can we see your ECG again?
Yes.
The presentation ECG.
You consider Prinzmetal's angina or coronary spasm as an alternative diagnosis?
Could be a possibility. I think, yes, that could be a possibility. But the way this was happening, and at that point of time, at one point of time, I thought, let me leave her on medical management and just because all arteries were flowing. But then if the patient is continuing to have angina, referred to you in the middle of the night with borderline hemodynamics, I thought I'll take a chance at least to do this LAD. And then we explained to the family that probably we'll do this. We find that the other vessels are not that critical, but in the future we may need to do that. But she's doing well. So
okay, let's ask Dr. Girish. Looking at this ECG, what is your interpretation?
Thank you, sir. I principally feel it is a dominant right coronary artery, and it is an RCA-related, probably inferior wall ST elevation MI with a recanalized thrombus. Probably that would be my first interpretation of this ECG, the echo, what I see. If you can show the RCA angiogram, please, the dominance of that vessel.
It's a dominant vessel, sir. It's a dominant vessel.
Yeah. So I would still treat, there's no harm in you stenting the LAD, but I would still feel the culprit is RCA because it's a super ST elevation inferior plus posterior wall MI. You look at 4 millimeter ST depression in V1 to V4. So this is such a big vessel. I would have done an OCT in this case. I know it may not be available to you, but if there is an objectivity to what you're doing, you will definitely see by doing an OCT, a plaque rupture, thrombus, that would guide you. But had you done a thrombolysis, what is your aim? To get TIMI3 flow. Already you have a TIMI3 flow in RCA. So you've achieved flow, and you think that it is not a flow limiting lesion, and you didn't think it's prudent to stent it, and you stented the critical lesion that you saw. But in my mind, the culprit vessel is RCA.
So I thought of it, that culprit vessel could be RCA and it's weak analyzed, but the kind of angina the patient was having and the ST elevation which was persisting, I was in double mind. I thought, let me revascularize the LAD in this scenario because it appears to be quite tight. In fact, we actually just took 1 or 2 shots of the LAD because we were prepared to actually go ahead and straight away stent the RCA. We in fact took a guiding catheter to begin with, even not a diagnostic catheter for the RCA. And then when we saw this, so I mean, yes, this is the reason I brought it to the audience. That one is
great. Yeah, one point, if I to tell you, Kuba, that the imaging has reduced mortality and reinterventions. Okay, so let's not underestimate the power of an imaging. So if we can have finances to establish a cath lab, I think we should insist on having at least one modality of imaging in our lab, because it makes great deal of difference. Not only, in your case, it would have nailed the diagnosis, which is the plaque rupture, which is the culprit vessel. Second, it would have given you a great result in terms of understanding the plaque, the length of the lesion, then morphology, what pre tools that you would have used before stent implantation, and then optimizing. I think please invest on imaging. That's the lesson for me out of this. Not trying to think which was the culprit, but we missed an opportunity to give the lady a better. I'm worried that she may have another event if there is a large ruptured plaque on the right side. She may have
let me counter that. I think I take all the points, but let me counter that. Now, suppose I did the imaging in this scenario and there's a plaque rupture in the right coronary artery with a TIMI3 flow and a critical stenosis in the LAD. Should I have left it at that point of time?
Yeah.
I think the FFR in this RCA would probably be normal, and the ST elevation was still persisting. Prince metal, as Dr. Keshamurthy suggested, is another possibility. Patient is doing clinically absolutely normal now.
So you should stress her. I think it's more than 2 months, and your LAD's result was very good. So you should stress her, and if stress thallium or regular stress test show an abnormality, you're still left behind something which needs to be corrected. Dr. Keshava, you have any comments?
Absolutely. We should do some kind of ischemia testing, either viability or whatever, and then proceed. And Dr. Girish Navalson's point is also well taken. Sometimes in ACS, acute situations like this, when you cannot decide what you do, sometimes you do intervene on lesions which look like they are borderline or 40-50%. If the plaque volume, the plaque burden, the instability of the plaque is an issue, you go ahead and stent them.
Oh, Dr. Keshavamurthy, I want to ask you one question. The LAD lesion and the ECG, do they match or they don't match?
They don't match. They don't match. I think RCA is the culprit, and it has recanalized, and everything is done stepwise and everything has gone off well.
In your cath lab, what would you do? I mean,
in an acute MI situation, if you end up treating the non-culprit vessel and there is a complication in the non-culprit vessel, then you kind of look at it, back and feel bad.
There is no complication now, but even then, I think we probably left the vessel which was giving trouble unaddressed.
Absolutely.
So I would probably feel that you need to do IVUS or OCT or something of the RCA and as well as LCX. Even now, since the patient is ambulatory, no symptoms, do a stress test to decide whether there is no ischemia from these two other vessels.
Absolutely.
Any other comments? Dr. Gaurav, you want to add anything? Gaurav, we can't hear you.
Sir, I agree. Whatever the discussion is going on, that ECG wise it has to be RC only. Whatever Dr. Samir is, showing up case reports and that explanation, that is only when we have ST elevation in anterior leads along with inferior leads.
No, that is
Probably-
what I'm trying to say. See, that is what I'm trying to say. This case report says isolated ST elevation in the inferior leads without any iota of elevation in the anterior leads.
Can we
My
see
reason
your
for
post?
presenting this was,
Can we
I mean,
see your
obviously we didn't have
post-posterior
imaging,
ECG?
and we would like to have had imaging, but I think in the absence of imaging, when we did not have imaging, this kind of lesions would have been treated medically in the cath lab with a TME3 flow. My question was, should I even stent the LED? Should I just leave her on medication, arrange for the imaging next day, do it that way? That was in my mind. But when you are in the middle of the night, a patient has been referred, continuing to have angina, hemodynamic issues, heart rate of 110, BP of 100, 110. I think it's a very difficult decision if you don't have imaging and physiology in your lab to be sure about it. And to do something, I have had issues in which there is a distal LED lesion which has caused ST elevation, absolutely normal RCA and circumflex, and patients have improved. And that was the basis of my decision of the LED in this scenario. If you look at the anatomy of the LED also, probably maybe it was collateralizing, maybe it was a RCA which got recanalized, whatever it is. But the way the patient was having clinical angina and ST elevation, maybe it would have settled with the medical therapy also and nitrates, and the stenting LED would not have been required. But it was very difficult for us, and that is the reason we got it.
Can you see your post-ECG, post-PCI?
Yeah, absolutely. The ECG is normalized. That is what I was trying to tell you, that this is the ECG, how beautifully it has normalized. Now, we can argue that it could be just a medical management also which could have normalized it. The way the ST has settled and the way the TE waves have inverted, I mean, you can say that probably it is even a medical management could have done that. But
Dr. Samir, what we are trying to think is the ST elevations got the patient on CAT table. Then we addressed a vessel which was probably not the true culprit, and a patient probably had a spontaneous recanalization, and what you're seeing is the benefit of that recanalization of the RCA.
Exactly, sir. That is the reason I brought this case for an expert opinion. That one is, we can keep on discussing that what was the culprit vessel, and short of imaging, obviously imaging will show us the answer. We don't have imaging. So, but short of that, in clinical scenarios, when you don't have imaging, I mean, how the expert panel would have managed. I thought that I had to do something to the lesion instead of just leaving her on medical management. That LED was too critical for me.
No, and get her back. I think if not anything else, at least do a CT angio. And CT angio would help you decide whether you have some flaps and things like that in the RCA.
Yep.
All right. Any other questions?
I think we'll move on to the next case. I think we'll discuss.
Thank you, sir. Thank you. Thank you.
Thank you. Thank you for that interesting presentation.
Thank you.
So who, Dr. Gaurav is presenting the next case?
Yes, sir.
Yes.
Okay.
I'll just share my screen.
Dr. Gaurav, I went to his lab once. He's close to Nasik and a very dynamic personality, very busy in his work. And he has, I think, 2 or 3 DMs working with you. So they are in a sort of a non-city situation. I think the dynamics with the work pressures are tremendous. And then they're doing a very good job. Gaurav, size blessing.
Yeah.
Very good.
Thank you, sir. You are always inspiration for all of us, and it's an honor to present a case in front of you. So, with your permission, can I start, sir?
Sure.
And good evening, chairperson and moderators. I'm going to present a case of complex angioplasty with, the dilemma still continues. What is the better option for all of us, angioplasty or bypass? Because of late we don't have recent trials to suggest that which is a better option to suggest to our patient. But whatever the data we have for triple vessel disease, still bypass scores over PCA. But in our understanding and our clinical practice, we have a confidence more in angioplasty, and this is what I will try to discuss with all of you, and will seek your expert opinion. So my patient was a very young 40-year-old male, no risk factors, admitted with unstable angina with EF of 40% and hypokinetic inferior wall. When we did angio showed a chronic triple vessel disease with RCA, almost CTO, osteal LAD and mid LAD disease and mid circumflex disease. The dilemma was about what to advise him, plasty or bypass. And just to show you about the angio, if you can see, this doesn't look like a artery of a 40-year-old male. This is a chronic occluded RCA with some flow there, which seems it's a 99% occluded, but as we proceed, we came to know that it was a CTO. And this was the LAD. You can appreciate there's a region.
Was it diabetic?
Non-diabetes, so no risk factors, and it's thin, no obesity, no hypertension, no family history, nothing.
No family history of diabetes also?
No, sir. And we were very much surprised to have this kind of angio in a 40-year-old male. We just, sometimes feel surprised that where we are heading to. Everybody is having these kind of diffuse diseases. And in 40-year male, the patient's relatives were not willing for bypass at all. I discussed with my, working colleagues who are working with me. Then we planned for PCI for these three obvious reasons: age, patient willingness, and we trust more in angioplasty than CABG for obvious reasons. And this is a thing which sir has already taught us, that you believe in your...
That last line is very important.
And sir, this is all your teaching, and we are really following you blindly when we are doing any angioplasty.
No, before we go further, what about LV function?
LV was 40%, sir, hypokinetic, but preserved LV function, LV thickness in inferior lead, sir.
LAD is very important. If this patient was to have bad LV, I would probably think surgery could be a better option. But anyway, let's see what you've done.
Absolutely, sir. So we started with a RCA first, it being a tight stenosis. So to our surprise, we couldn't cross antegradely. There were different wires which were tried. We tried cross-A to start with, then Fielder was tried, then Gaia 2, 3, but we were not able to cross. Finally, we have to leave at this place that there was some dissection, hematoma. So we left it at this place about the RCA. This moment we were thinking, and when we reviewed, we could understand that actually it was a CTO. It was not a 99% stenosis, subtotal occlusion. You can appreciate there are some collaterals in bridging collaterals in between, which were just filling the RCA, and actually it was a chronic CTO, which we actually missed on angio. So again, the plan was whether we should continue or send the patient for bypass. But we thought that...
let me check with Dr. Keshavamurthy. Now, right is not gettable. So we stop and send him for surgery, or we continue to work on the left?
Yeah. My policy is below the age of 50 years. I would be very reluctant to send this patient for CABG despite a high syntax score, and that RCA would give another serious attempt because he is a reasonably young patient, and I would...
No, he has tried everything. He has tried 3-4 wires.
Yeah.
I mean, if you're talking of say some referral to other center, it's a different issue.
Yeah, but surgically also RCA wouldn't receive a graft with that kind of disease. The distal vessel is not seen.
Gaurav, can you show us the distal RCA?
Yes, sir. Sir, can I show the left shoot? The retrograde is feeling nice. Should I show that?
Yeah.
whatever, whichever way you can
So-
show us the distal
So
RC.
we thought that we'll try retrograde, and for that we took left shoots, and you can see there quite a nice filling of the RC from both the ends.
Definitely good graftable vessel.
Then
Yes.
bypass is a possibility. Yeah. What about lipoprotein little a in these patients?
Sir, we actually routinely don't do it. I don't know whether it's a recommended thing to do in our setup. Absolutely, in Southeast Asian they are quite high, but we are not in a habit to do it. What is your, sir, policy? Do you do it?
And how
Yeah.
do you treat it?
We were not routinely doing prior to getting into the horizon trial. And when we got into the trial, we started pre-screening a lot of patients. We found that a significant number of patients like this, young and without any other risk factors, without family history of coronary artery disease, non-smokers, they tend to have a very high lipoprotein A.
But sir, having
We started doing it routinely.
sorry to
So how
interrupt.
do you
Sir.
treat it? But
Yeah, absolutely, sir. My point.
We have now evolocumab, which is available, and we have started using for acute MI and acute coronary situations where there is evidence of very significant reduction in LDL and LPA, though the hard endpoint data is in process. Means once the horizon trial comes out and we have more data on hard endpoints, we would be justified. But as of the moment, we have reserved treatment of high lipoprotein A to patients who have an acute coronary event or acute stroke or TIAs.
Sir, Dr. Murthy, if you can ask, how many people you advise and how many take these PCSK9 inhibitors? Means in our setup, they're very scanty to follow the things, and then we don't have a guideline that how much duration should we give. So, what is your take in this?
Yeah, this point has been discussed in many seminars and even in the international. How long to continue these patients because of the cost issues and insurance coverage, and especially in our country, to give an injection which is about 20,000 rupees every 2 weeks is not a viable option. So currently, like when you're looking at plaque passivation, just like you think of a period of 3 months as the hot plaque period, that is the period we are looking at in these patients. That's why we have chosen these acute coronary syndrome, acute event patients, rather than a chronic stable patient who has high LPA.
But do you repeat them again, sir? LPA sequentially? Do you repeat 6 monthly or 1 yearly?
Yeah. Means in the trial, means I cannot reveal the trial data, but out of the trial, when we have seen patients at about 3 months, as early as 30 days, some patients have checked on their own and had a significant reduction, almost more than 50% reduction in LPA.
Oh, fine.
And of course, it's positive benefits in terms of LDL reduction, which is collateral, and also the events, which I think the data will be positive.
So, should I continue, sir?
Yeah, please go ahead.
So we thought of good collateral from the left side, which were obviously on angio also. So we thought that we'll try these collaterals and try a retrograde before finally signing off that we can't do angioplasty, or we can wait for some time. So we started with a workhorse wire over a micro catheter, and we were lucky enough to find a good collateral inside the RCA. We could cannulate distally with the microcatheter inside the distal vessel. Then we tried initially with the Fielder XT wire, thought of that we may go inside, but it didn't budge further. Then we had to take hard wires. We started with prostate, but it was going somewhere else. Then we started with guy 2, and then again changed to CrossFit 300, but it was not successful. Then we tried with 2 other wires, but finally the Gayatri worked for us. And finally we could get into the guide catheter. Then we exchanged with the RG3 wire and did a sequential dilatation with 1.5 balloon and 2O balloon. And gradually then we did IVUS, and which showed a calcific tight plaque. These were the images of different areas. Finally, we stented with 2 long stents, and you can see that this was the tightest portion in between from where we were stuck in between. And if you can see the result, it was just a excellent RCA, super dominant RCA, which was not seen initially. We did a post dilatation as well, and this was the final RCA shoot, which was not apparent when we started. So as sir said, Hiramat sir said that RCA was a sizable, graftable, big vessel, and we were not, finding it that way during the first initial angio. Then we shifted to left system. I did a small stenting to the circumflex. This was the circumflex result. And you can appreciate there's a osteal stenosis in the LAD also. So we repeated I was there. And there were some fibrocalcific plaque. Then did a sequential dilatation and put a long stent in the LAD and finished with this. So this was the final result of angioplasty on the left system. Of course, we repeated I was to confirm our results. And this was RCA. So the point to discuss what I want to have your opinion as well as that barring few conditions, probably like sir said that PCI is now equivalent to CABG, and we do get a good satisfactory result with imaging. And probably with still more better advancement, we may replace CABG in almost all cases. So I'll like to have your opinion in triple vessel disease. What do you follow, and what is the advice at the present guideline directed thing that what you should do?
I think at the outset, I should congratulate you. It's a wonderful work done. But if if you look at the philosophy of revascularization through CABG versus angioplasty, if there are focal three vessel disease, or at least even four lesions covered with stents, with diameters of probably 3 or more, I think you may be able to match a bypass surgery. But if you're going to have a stent which is probably 2.5 millimeters longer than 23 millimeter, and you're going to use 2 long stents causing endothelial dysfunctions. Many of the time when we do a CTO, many side branches get compromised to a varying extent. Sometimes when you do aggressive post dilation, they even get pinched. So I honestly don't believe that in every case angioplasty is going to be equivalent to bypass surgery. The beauty of bypass surgery is when you graft a lemma to an LAD, distal LAD, 2 things. I don't think stents have ever shown to be superior to lemma. They've been superior to venous grafts. Second, once you have grafted the distal LAD, even if the patient develops
why do you say that? I mean, if you stent LAD, the LAD remains patent for next 20 years or 30 years also.
So I wish, sir, but I think lemma
I would very strongly object to this statement.
More so, Dr. Girish, so like in this case, the age is 40, we are buying time. Maybe if they...
I agree. I fully agree. But if I may be allowed to complete, if you're going to revascularize a distal LAD with a lemma graft, even if he develops 5 more lesions in the ostial LAD, left main proximal LAD, he is not going to be symptomatic. There are not going to be events. That's the only superiority of revascularization by bypass compared to stents. If you do a 40 millimeter, 48 millimeter, even if he develops at any one segment a lesion, then he's going to have events and revascularizations. That's the only way. But at 40, absolutely, I would not send somebody for a bypass. And you need to have a lifetime treatment options for a patient. So what you did, I concur. But then again, what's important, you have one great chance, give the greatest result, like use imaging, strategize well, don't lose large side branches, and don't implant a stent where future bypass locations are going to be like PDA, distal LAD or OMs. I think if you can match that, I think you've done a great.
Totally agree, sir. Thank you.
Very valid points of discussion by all the discussants. When patient has multivessel disease and a high syntax score, proximal LAD, proximal vessels diseased, and diabetic. Diabetes is one thing which completely changes the picture in everyone's mind because the vessels are small. And the data also supports that in diabetics, CABG is superior to multivessel stenting.
I would feel LV function also contributes to the decision making. If LV function is bad, cabbage is better than PCI.
Of course, sir. Absolutely.
Right. And in many of the trials comparing surgery versus multivessel PCI, the problems are because of the revascularization and the events, the target vessel events and the non-target lesion progression. If you see really patients have a higher risk of events rather than mortality difference between CABG and multivessel angioplasty. So when we choose patients and kind of subject,
I think with the age of 40 years,
yeah.
I think what Dr. Gaurav has done, I think it's outstanding.
Absolutely outstanding, and there is no doubt about that. Only thing as interventional cardiologists we should remember is that when we are competing with bypass surgery in multivessel disease, our revascularization should be very selective. And like Dr. Girish pointed out, the length of the stents, the size of vessels you treat. Now with the advent of drug-eluting balloons and physiology and imaging, if you choose your vessels rightly and use lesser number of stents and leave the vessel open for future bypass or whatever, that would be the ideal from the patient point of view also.
Okay. Do we have time? I can show one case if
Please,
you all
sir.
agree.
Yes, sir, sure, sir.
Please, sir.
So this is an important update. I think Dr. Hiramat sir wants to share one case. So I request RX event, Sagar, to make Dr. Hiramat sir as host so that he can share the screen. Yes, sir, we can see the screen. Only you can just make it full screen.
So this is from our Ruby Hospital, this case. And this was a 69-year-old lady. Actually, her husband had undergone an angioplasty about 4 or 5 years back. And the day she came to our outpatient, her story was idhar dukta hai, udhar dukta hai. So my fellows, they felt we should put her on treadmill. Her resting ECG and echo were normal. And on treadmill, she had a very strong positive test. But look at her age, 69. Her weight is only 40 kilos. She has diabetes for a long duration, something like 10 years. And serum creatinine was 1.33 with eGFR was 55. So there were many points which were sort of against an angioplasty. But this is a lady who was sort of working day in and day out in her home and never said she had pain. She was going on. And we stopped the treadmill test just at 1 minute because she had strong ST depressions. I think maybe I have a slide of the ST changes also. But on angio, we find a critical lesion in the RCA ostium, and then circumflex, which was again 99% going here, and criticality at the diagonal origin. Mid LAD is also diseased, left main long and having some degree of narrowing at the distal end. We felt the circumflex could be the culprit vessel because she was complaining more of breathlessness, and we felt that maybe she has a mitral regurg related to the circumflex, which was there. So the discussion was whether PCI or CABG. I think age-wise, she could go either way. She was 69 years. Who is moving my slides? Please don't move.
Sagar, please give control to Dr. Hiramat sir. He will move his slides.
Yeah, I have. Yes.
Sagar, are you there?
So after discussion with amongst ourselves and with the family, we said we will go for an angioplasty. But mind you, we had an important subtotal occlusion in the proximal RCA, which was a dominant vessel, a critical lesion in the circumflex, as you can see here, and the mouth of the diagonal as well as the circumflex. They were showing disease in the mid-LAD, and some narrowing at the distality of the left main. Again, left main was a very, very long lesion. When left main is long, I think your guide catheter, which is at the ostium, will probably not be able to help you a great deal to give you support from behind. So in this case, we decided we will do the right first because it was a relatively simple vessel. We used guide catheter. This is a M+2. And here we are staying out of the coronary ostium. And this was wired, ballooned, and then we put a stent. And it turned out to be a huge vessel. So what was like a total occlusion and looked like a small vessel turns out to be a big vessel. I think this kind of achievement, it will probably add a lot of safety to the left-sided revascularization, which is going to be quite complex. So you can see here what looked like critical stenosis and not a very big vessel, but turns out to be a big vessel. So once this has happened, there was a lot of hemodynamic stability also, and we decided we'll proceed with the left circulation. Now, I think all of us must give importance to the length of the left main. This was almost 60 millimeter long left main. So your guide catheter is far away from the criticality of the lesion. And this is not very good news. So in this case, we did the simple RCA first, and it was a big gain because I think a lot of blood started going to the heart, and probably some collaterals would also give supply to the left. Then we thought we'll do the mid-LAD, which is a simple lesion first, and then go to the circumflex because patient was getting mitral regurg related to this critical ischemic circumflex, and then do a kiss here, and then do a kiss of stent here, and then the stent coming back to a left main. That was our plan. So in this case, we took a Fielder XT into the circumflex. It was then redirected through a microcatheter to the, you can see it is pulled back and it is redirected. Now you can also get catheters which have one hole which is going proximal. So the catheter, microcatheter would be directed to this vessel over this, and you can push another wire from the side into the whichever vessel you want to side range. In this case, of course, we managed it, Fielder. We took an XT because lesion was quite tight. And so once we ballooned this, we took hypercoat down the LAD. Fielder XT is there in the circumflex. So the mid-LAD is then ballooned, and then we plan to put a stent. So this is a stent in the mid-LAD. Now we are staying clearly away from the mouth of the diagonal as well as the opening of the circumflex, as you can see here. So we had to take repeated pictures. We also had worry about serum creatinine and only 40 kilo lady. However, there was some kind of wire entanglement, and we could not put a NC balloon to post-dilate the stent. We thought we will do it at a little later stage of the procedure. Then we withdrew the LED wire because it was not allowing the balloons to go towards circumflex. Now we have a microcatheter going to the circumflex here because we wanted to get the balloon. You can see the balloon dilatations, and through the same microcatheter we got a stent in. So the stent was positioned from the mouth of the OM, this is the OM branch, and this is circumflex. And so this is how it was positioned. We thought we'll finish the stenting first and worry about the post-dilatation at a later date, because she was going into failure again and again. After this, we did a balloon dilatation, NC balloon dilatation to the deployed stent, and the wire was switched to the OM. So here the LCX stent in position. We opted for mini crush because we wanted to not to have any stoppage of flow at any stage. So mini crush is a safe strategy from this angle. Now here the stent in the OM was not going any further. So we had to actually withdraw the wire in the OM. And then the stent went. So here the stent is going up to the circumflex. This is deployed. There is a wire in the OM. And we pull the same balloon back and go high on pressure, because we may not be able to take a balloon. We may not be able to take a wire into this later. So same stent balloon, you withdraw a couple of millimeters back, then go high pressure, maybe something like 18, 20. And so that even if you can't do a NC post-dilatation, you're okay. So once the LCX stent was deployed, we are working on the OM. You can see here the stent is starting at the beginning of the circumflex going to the OM. And this is deployed. Then we are working on the diagonal. And you can see a wire in the diagonal. This is an NC balloon. And then the stent comes in. The first stent, which was deployed in LAD, the back end is away from the bifurcation. So this is a stent in the diagonal. And then we got a stent from left main to LAD. So there is going to be a mini crush between this stent and the left main LED stent. And so this is how it is. We deploy the diagonal stent, and you can see difference between this one and this one here. The same balloon, stent balloon, is withdrawn so that you don't get any distal dissection. And go high on pressure. the stent in the left main and LED is in position but not deployed. So once we are happy with the this thing, you can see the position on stent boost. So this is going towards circumflex, this is to OM, this is to diagonal, and this is to LED, and this portion is in the left main. And you can see here the proximal LED and left main is inflated. Then we do a pot. Even while doing a pot, you must have an adequate length. Most of the pot balloons are 8 millimeter in length. Occasionally, we have 6 millimeter available, but keep a decent length in the main branch so that you can do a high pressure pot inflation, as you can see here. So this is a pot balloon going to probably about 25 millimeter balloon. And this is the kind of flow we achieved. This was the beginning, and I will show you pre and post here. So we rewired the diagonal and did a pot to diagonal. And this is actually a simultaneous NC balloon dilatation to diagonal and LED. Then we did a simultaneous balloon inflation to circumflex OM and the left main LED. And we actually did not do NC dilatation to the circumflex branch because it was too difficult to rewire the circumflex. So these two, so this is basically a mini crush kissing balloon with an NC, and there was this repot with a 5O NC going to high pressure. And this is the final result that we have achieved. So there are two stents in LED left main, one stent at the mouth of the diagonal, one stent going from circumflex ostium to the OM, and another stent in the circumflex. So this is the only bifurcation where we did not do a kiss, but all other bifurcations we were able to do a good kiss. And this is the final pictures. Good flows in the LED left main area and into the side branches. So this is how we started. This is before and this is after. And you can see a good flow improvement and a good stent expansion. So we were very happy with what we achieved with mini crush. It's about 8 months now, and patient is doing very well. To summarize, we did the right coronary first. It was an important big vessel, and it was easy to do. And he did mid-LED next. Then we did the circumflex. We did a mini crush between circumflex stent and the stent going from ostium of circumflex into OM. And then we did a mini crush between diagonal and left main LED stent. And this is how the final result is. Quite some time, about 8 months, as I said, and both patient and her husband had an angioplasty about 5 years back. And the lady was very impressed that somebody who couldn't even walk in the farm was able to do all day's work and full functionality. So actually, this is a patient who sort of offered herself to be tested and see what level of seriousness we find. Thank you indeed for your attention, but we could take some questions also.
Thank you, sir. Highly inspiring again. Only you can do this kind of complex double mini crush, I will say. Probably you have done L6 OM, and there was a very slight margin between diagonal and OM. So do you find difficulties, sir, in crossing stents in these narrow vessel, the margin is very less?
Oh, you mean we are deployed this stent number
Yes,
3,
sir.
which is
This
coming
one,
back,
yes, sir.
and then you are taking a stent into diagonal.
Into diagonal, yes, sir.
So this is what you're asking, whether it was difficult or easy. I think this stent, we did aggressive NC dilatation. And at that time, we had a balloon in this area. And that allowed no back projection of the stent. And that could allow a stent to go into diagonal easy.
Okay.
I think
Thank you,
this
sir.
was a lady from Absolute Village, and we had to sort of write in her discharge summary, ever to stop the antiplatelet therapy. Our worry is she's only 40 kilos, and she was on Brilinta and aspirin. Any comments, or anybody would have liked to do it in some other way?
Thank you, sir. That was a wonderful demonstration of your skills. But the culprit is the RC, and we would exactly treat the way you treated it with an osteal stent. And when
No, culprit I thought was this circumflex,
possible,
because she had mitral regurg every time she had angina.
yeah,
The mitral regurg used to get worse.
yeah.
And when we have finished, the mitral regurg improved from about class 3 to class 1.
Yeah. And the more and more I see the trifurcations and the complex lesions like this with extreme angulation of the branches, the less and less I am inclined to put stents. So I would have just treated the left system with a drug-eluting balloon at the most critical lesion in the ostium of the circumflex and got out without a stent in the left system. That is my personal view on this case.
I mean, everybody has different ways to look at the drug balloon. Yes.
Means
But,
all the subsequent events will happen in this crushes or multiple stent situations on the left system. She'll be absolutely fine with the right, I'm sure. So to avoid subsequent events at bifurcations and trifurcations and this crushed stents, I don't like crushing things, metal in the left system, especially at the left main bifurcation. And now with the availability of drug-eluting balloons, our options have become quite open now. And now we are not afraid to put a drug-eluting balloon to the circumflex ostium at a simple stent across the left main into the LAT. That greatly simplifies the procedure and also reduces the side branch events.
Yeah, but stenting give us more safety and security. With DEB always there's a chance of dissections, and we are not at the moment we are not that confident with the DEBs in left main especially.
Yeah,
what
a
I'm
great
saying
deal
is
of
very
discussion.
true, because even if we use drug balloon and end up with a dissection, which we are not seeing on angiogram,
Yeah.
I think there could be a problem. So I would feel very safe doing this kind of case only with stent. I would not consider
I agree.
drug on this at all.
There was a great deal of discussion and several presentations in the TCT this year about this issue of what to do when there are dissections and you see haziness and all that. But if you have imaging in hand, and even if you don't have imaging, the vessel size, the minimal luminal diameter seems to play an important role. If you have a good MLA at the end of the procedure, even with a small dissection, the classic angioplasty we used to do earlier with the plain balloons, we are now able to do with a drug-eluting balloon and get a good result in intermediate term also.
I think, sir, I have, I think it's somewhere mid-path is maybe better, but Sir, Hiremat sir is a connoisseur of, how complexities can be handled if there is a need. I think that is how I would look at it, but I am sure most will not be able to do this or won't even consider doing this.
Absolutely.
Absolutely. So if it needs to be done, and this is how gracefully it needs to be done, and so thoughtfully strategizing, making sure that placement of one stent does not impede the revascularization of other segments. But again, looking at the durability of therapy is what is another aim of coronary artery disease treatment. One is acute gain that we have. And as Dr. Keshamurthy also mentioned, I think that if you achieve an MLA of more than 4.5 millimeter square, most of the time, stent will do a good job. But if you're going to have an MLA of less than 4.5, there are going to be events. And if for every 0.5 millimeter reduction, events are going to be significantly higher. So please consider what size of scaffold you're going to implant. And see, this is a generation that has not used balloon angioplasties at all. And if people who have been comfortable doing balloon angioplasties and have had an experience without scaffolding with a stent, they would know how to do a balloon angioplasty. But most others, if you just tell them, use a DCB and you will get away with it, maybe they do not know the implication of just doing balloon angioplasties. I think there is a lot more learning to be brought into focus for non-stent angioplasties.
I would probably that do a perfect balloon angioplasty, and then only your drug balloon will work. So at the end of balloon, you should have no dissection. You should have opened the vessel completely, and the drug balloon will just deliver the drug into the vessel wall. So all of us like to keep the drug balloon pressures to just about 6 or 5 and 1-to-1 diameter with the vessel diameter.
True. I think we need to achieve a residual stenosis of less than 20%. No dissection more than 3 millimeter, more than 2 quadrants, and no hematoma, intramural hematomas, TIMI3 flow. Only then I think the drug balloon can go there and deliver the drug. So the fundamentals remain the same, but we're still learning about how to use a DCB. But it's a great insight because you're always considering temporary scaffolding of the coronary artery, not a permanent scaffolding. And if we achieve that, I think we may compete with bypass at that point in time when we don't permanently scaffold the whole vessel. Thank you.
I think when we stent long in LAD, like in this case, our stent ended somewhere here, and this portion of the vessel, from this point onwards, the vessel is not stented. So you must think that, yes, if patient needs surgery at some time in future, there is a space for the surgeon to graft it. But what about, there are surgeons who actually remove the stent which is deployed. Any comments on that, Dr. Keshwa or Dr. Girish?
Yeah, there are some surgeons who have done endarterectomized stents, so to say, especially when there are long stents in the area where they want to graft. But once that happens, there is a significant endothelial damage, and the patency of that native vessel is not too good. Surgeons are not very happy doing that, but they do when it is unavoidable, when there is no area to graft.
Quite true.
I have no experience, sir. How many of these surgeons you know, sir?
Very, very few. Very few. And very selected cases.
Because probably if it's a short stent, I can imagine. But if it's going to be a 33 or 48, I think that's more traumatic than not doing anything, I guess.
Absolutely.
So with the permission of our course director and moderators, can I take one question from the comment box by the audience? There is one question posted. So the question is, what is the prognosis in diabetic patients post PCI rather than CABG?
Dr. Keshwa, you want to take that? Or?
I think we discussed this question, and I made a mention that in high syntax score patients, especially diabetic patients, CABG scores over PCI in terms of reduced revascularization rates. There is a very small change in mortality And as interventional cardiologists, we always tend towards intervention. But when there is a patient with multivessel disease and diabetes and high syntax score, surgery does seem to do better.
LV function, you have any comments on that?
Yeah, LV function, we tend more towards surgery, like you said. Yeah.
Surgery, yes. I mean, many people think that if LV function is bad, surgery would be very risky, but in effect, it is discovered that poor LV, bypass surgery gives better results than
do better. Yeah.
Absolutely. I think this is another area where DCB is going to have a better impact than small size stents like 2.5 millimeter stents. I think this is an evolving field, diabetes and diffuse coronary artery disease. I think DCB will have a role to play here.
I think as an angioplasters and probably the patient is in connect with us for a longer duration than the surgeon. We must know where the surgeon would be able to graft at a later stage and not put stents in the areas where the surgeon can possibly graft later.
Absolutely.
I think that's a great statement. You also should know what is the strength of your surgeon. Very often, they just look at the coronary artery and they say bypass. But many of the surgeons may not be able to do a job as good as probably you could have done. So it's very important to know the strength and limitation of where we are working and choose the right therapy for them.
And also the
Okay,
concept
case,
of
I think
vascularization with CABG is also a myth. Like sometimes they take up, like you pointed out, they take up cases saying we'll do 4 or 5 grafts, but then the vessel is not approachable anatomically or it's too small intraoperatively and ends up being not revascularized, which you would have otherwise revascularized with a DCB or a stent.
Dr. Rishikesh, I think we are coming to the end of today's show.
Yes, sir.
So
So
maybe-
any concluding remarks from your side before then I will give vote of thanks.
I think we had very good discussions on multivessels today. Dr. Kupa showed a very exciting case as a first case, and we should sort of make sure that whenever you're doing multivessels, I'm not saying single vessel should be done easily or quickly, but especially when you're doing multivessel, you are probably taking away the chance from surgeon for a good complete revascularization. So multivessel stenting, you have to be doubly careful and probably use the best quality stents and best deployment techniques to come out with results which are probably going to be comparable to surgical results. Okay, Dr. Rishikesh, we can call it an end today.
Yeah. So we are nearly at the finish line, but before we conclude, let's express our gratitude to all who made this scientific program possible. I extend my deepest gratitude to respected course director, Dr. Hiramat sir, for the guidance and expert comments and also presenting the third case. So today is an amazing experience for the audience also that 3 cases were discussed. I would like to express my sincere gratitude to our distinguished moderator, Dr. C.B. Keshavamurthy sir and Dr. Girish Navsundi sir for sharing their knowledge and expertise with us today. I would also like to thank Dr. Gaurav Verma sir and Dr. Samir Kubba sir for their insightful case presentation. Your contribution has undoubtedly expanded our understanding pertaining to the cases discussed today. I would also like to thank our esteemed audience for their time, continued love and support for this No Thrombosis program. On behalf of Emcure, I extend my heartfelt thanks to everyone from sales, marketing and medical team at Emcure who have contributed to this program's success. So let's carry this knowledge into our practices, research, advocacy and fostering a healthier future for those with cardiac diseases. Thank you once again for attending and encouraging us. Good night and good time ahead. Thank you.
Thank
Good
you,
night.
sir. Good night.
So we have
Thank
got
you,
the
sir.
audience of close to 1200 plus. I would like to
Wow.
inform and thank all the the renowned doctors in the industries.
Yeah.
Thanks a lot.
Congratulations to the entire panel and the speakers, moderators, and our respected course directors. Congratulations to everyone.
Hiram,
Rishikesh, you forgot to thank Emcure who has brought us together today. So I think on this front, Emcure has done a phenomenal job, and I'm very happy that Emcure is from Pune, and I'm also from Pune. And the Emcure boss, Satish Mehta, is from my school too. I mean, he was 1 year senior to me. Yes, very bright student, and he was amongst the top few who come in the SSC board. And so,
Thank you.
Thank you to everybody.
Good night, sir.
And thank you for the lovely audience also for their constant support for so many months. Every month, our participation is rising a lot. Thank you everyone.
Right.
But 1200 is a phenomenal number. No?
Yeah.
I think we must congratulate Rishikesh, you and your team, to have taken so much effort to get so many. So get ready for the next presentations, maybe a month from now. We
Yeah,
will
18th
announce the
Jan.
date.
Yeah.
But those
Third-
who want
third.
to present cases can communicate with Dr. Rishikesh, and we will have them set up for the meeting. Thank you and good night.
Right.
Thank you. Good night.